www.mente.com'a girin veya fotoğrafı çekin. Karşınıza sorular çıkacak. Konuşmalarla ilgili oylamanızı rica edeceğiz. Vaka sunumlarına geçmeden önce. Evet, süper. Michael, we are voting the subject. They need or not. 8 tane herhalde şu an girişimiz var. Girebilirseniz ne kadar çok kişi girerse o kadar bilgi olur ve bir sonraki toplantımızı organize ederken bize gerçekten faydası olacak bunların. Tamam mıyız? 15'ten daha kalabalık. Wow, perfect. Tamam. Sonraki soruya geçtik. I'm so sorry, it is Turkish. Giderek artıyor. Peki. Nöroperyolojide robot. Daha fazla kişi bağlanmaya başladı. Güzel. Aşırı aktif mesane ve laparoskopik pudendal sinir stimülasyonu. Kolorektal nedenler. Güzel. Nedenler. Güzel. Peki, son 2 kaldı. Muskuloskeletal nedenler. Son konumuz nörolojik değerlendirme. Merak ediyoruz, acaba sizlerin ilgisini çekti mi? Peki. Çok teşekkür ederiz. Tamamladık, değil mi? Ben şimdi vaka tartışmalarına geçeceğiz. Vaka tartışmalı biz kendi aramızda İngilizce olarak bir kesinti uğramasın diye konuşacağız. First discussant is Ahmet Kale. I would like to invite all speakers to the table. Please take a seat, please. Hocam siz okuyun isterseniz. İngilizce.
Siz geldikçe
And this is our, while evaluating our chronic pelvic pain patients in our clinic, this is our routine examination and routine follow-up routes. Maybe it can be discussable. We don't say that this is 100% true. It can be discussable. And also this is a case, now I'm giving a lecture about this case. 20 years old woman came to our clinic with gravita 2 and parita 2, and she had an anamnesis with spontaneous vaginal delivery. And she has been suffering from pain for 36 months. Do you have an idea? The woman or girl came to your clinic and our clinic, and she's saying that she has a pain during 3 years.
Ahmet, what's the location of the pain?
Okay, we are going on. Location is spreading from the clitoris to the anal area, the unilaterally. Yeah.
So what makes the pain worse?
During sitting, the pain is working, and while in the morning, no pain, but after, during the night or during the evening, the pain is increasing. And it is your answer. Characterization of the pain is unilateral, and it is an like somatic pain, sharp, burning, and numbness. And also, your question: what does the pain start from the left realm and going to the clitoris and anal area? Yes, this is the pain doesn't radiate to the upper or lower part of the body, and just it is localized to the perianal area and vagina. Do you have any more questions?
But we have an answer.
I said that I got it.
Well, she has one of three things. She has either duodenal larger spastic pelvic floor or pelvic congestion.
Yeah. We also think three of them. First of all, as you think, yes. Another
I know what it is.
Another opinion about this case.
But if the congestion, don't you think that you will expect to have the bilateral?
Yes, no, well, usually congestion is worse on the left because of the left ovarian pain connects to the renal.
But still, you'll have the bilateral.
Well, I just said, I just didn't want to say the one that's most obvious.
Order, we are going on. Okay. It is one of the most important questions we are asking. Does your pain spreading to your legs? If any pain is spread to your legs, it means that it is related with sacral nerve dermatosis, sacral radiculopathy. So it is an important question. Okay, it doesn't radiate to the legs or discal hernia. Okay.
I have to disagree with that.
Ahmet, is there any vegetative symptoms or is there any bladder problem?
Yes. There is a bladder
What's the problem? What's
frequency of the bladder. Yes, 10 times or 8 times a day.
Is there any incontinence, urinary incontinence or
incontinence,
rectal?
but frequency. She says that 10 days a day I am going to toilet, but doesn't void completely. Do you want to ask any risk factors for pain? I gave a little bit.
Yeah. Using bicycle.
After coitus,
After coitus, yes, during during sexual.
Does she pain?
Yes.
Does she pain after coitus much?
Yes, after coitus pain is increasing.
Yeah.
Okay.
Was there assisted delivery?
Yes, not assisted delivery, but just only the risk factors is macrosomic fetuses.
When was the time of her last delivery?
When was the time?
Of her last delivery, because you mentioned about
3 years. 3 years before.
Okay.
Just only risk factors for our case is macrosomic fetuses. 4,000 kilograms, grams.
Any complications during delivery?
No complication, but in her analysis there is an episiotomy. Vaginal nerve reading and episiotomy, risk factors. Do you think about the WAS scores, WAS pain scores? Do you ask the patients WAS pain scores? Yes, we ask the WAS pain scores to the patient. This is Mr. Barish's questions. Yes, there is a pain during intercourse, very severe, and she says that the score is 10 to 10. Okay.
Can I make a point? I'm sorry.
Yeah.
It's not a question, it's a comment. What he said is actually very important, that every patient that has pelvic pain has pain during sex. That's everyone. But the fact that the patient has pain after sex for a day or two, that's very significant.
Yes.
Because that really differentiates the pelvic floor pain from like endometriosis, interstitial cystitis. People that hurt for the next 2 days after sex are either pelvic muscle spasm or penile.
Also menstruation, mild. During menstruation, pain is mild. And also, we ask, does the pain increase before the menstruation? No, there is no. This is important. Is there any pain during prolonged sting? Yes. During sting, the pain is increasing. It is an important question. This is Dr. Tanner's question. Is there any pain when the bladder is full? Yes. How often do you urinate? 10 times a day. I am going, but I don't completely voiding. And nocturia, sometimes a night 3 or 2 or 3, 3 or 4 times.
During daytime.
Daytime. This is another important question Dr. Michael asked. Yes, the pain awaken from sleep. We are asking about the pudendal neuralgia. No. But only risk factor is pain is aggravating during the sitting. Do you have any other examination?
Yes.
What
There's
do
an
you
exam
want to
of
do?
pelvic muscles.
And also tight muscles.
Tight muscles,
Sinuside.
pelvic floor, hypertonic,
Sinuside.
Rectal examination.
sinuside, rectal. What do you think about rectal examination?
If there is a fistula,
Yeah,
there is a chronic fissure,
yeah.
you should
It
rule
may
out.
relate
Yeah.
to pain, yeah. Okay, this is our examination. External pelvic organs or genital organs are normal. No infection, we looked about infection. Vagina and cervix is normal. And during cervical motion, cervical no tenderness, uterine mobility is normal. And we look at the transvaginal ultrasound, it is normal. We make a neuropelvologic evaluation, asymmetry of the perineal region, and we also look, as you asked to me, yes, there is an hypertonic left ovorectalis and oviposicalis muscles. But there is no fistula or any other things about gastrointestinal symptoms. This is important. TINA sign, Mr. Barish asked me. TINA sign is positive. When we touch the sacrospinous ligament during vaginal examination, pain is increasing. This is our sensory examination. Left side allodynia and somatic pain, hyperalgesia on the left side of the perineum. It doesn't relate to the groin or the buttocks or the legs, and neurologic examination is normal. Do you think any laboratory evaluation or consultation about this patient?
Ahmet, do you think that can you apply urodynamic evaluation of this
No,
patient?
not routinely. Not routinely. Because
In which condition do you apply to urodynamic assessment?
if the patient has an incontinence or maybe mixed incontinence or not stress incontinence, maybe urge incontinence, and the incontinence interval is long, may be needed, but not routinely. I don't.
What's the urological aspect of this case?
Routinely
You don't need exactly the
Yeah.
urodynamic evaluation in this patient
Yeah.
situation. Maybe after a medical evaluation, medical treatment, if you don't have any success, then you can think a urodynamic evaluation after that.
So I agree with you guys. I mean, there's really no need to do urodynamics on her because she doesn't have urinary symptoms really other than nocturia. However, one thing that is good about doing urodynamics is that on urodynamics you clearly can demonstrate pelvic muscle spasm. So normally you have to trust the physiatrist, the physical therapist that the patients have muscle spasm. You take their word for it because we physicians are not trained to examine that. I mean, you are, but we are not. But when you do urodynamics, well, we're surgeons. But the mid-urethral pressure, mid-urethral closure pressure, very nicely corresponds with the amount of spasm in the pelvic floor muscle. So if you did that exam, you could demonstrate that.
Okay, thank you very much. Any other additional laboratory evaluation do you want? Okay, we are going home. We made these tests, they are normal. MRI, we also made MRI, it is normal. Pelvic neuro-MRI we made. What is your diagnosis? Michael said three of them, vascular congestion of the and pudendal neuralgia and hypertonic pelvic floor muscles. Do you have any other diagnosis with these cases? Dr. Barish, what do you think?
I am agree with Michael Gilmer.
Okay. Dr. Taner?
Yeah, I completely agree.
Okay.
I'm wondering,
VT pudendal neuralgia. Yeah.
I'm wondering the algologist aspect.
Yeah.
I would perform, or I would let you perform diagnostic pudendal blockade
Block.
somehow. Yeah.
We think that pudendal neuralgia. Yeah. How do you confirm the diagnosis? You think that this is a pudendal neuralgia? What is your tool?
Pudendal block.
Yes. Yes, we made a block, transvaginal pudendal block diagnostic, and 10 milliliter local anesthetic, 4 times we made cerebrospinous ligament, transvaginal route, and then after VAS course decreased over 50% after the first pudendal block, 1 week after. And also we confirmed the diagnosis that it's a pudendal neuralgia cases. What do you do after this case? But there is a pudendal neuralgia, you are facing pudendal neuralgia and you make a block and the pain is decreased 50% and you made a diagnosis. What is your route? What can you do this person? Or this woman? Physical therapy. Yes, we offer physical therapy.
I would apply Botox injection.
Botox, another option.
Prognostic blockade with steroids and local anesthetics for the second time in order to emphasize the real pain relief or in order to emphasize the diagnostic value of the blockade. And afterwards, if the person is me, I would perform radio frequency or ablation. But if the person is gynecologist,
If your blocks and steroids
work.
work, will you make another thing?
No, until the pain. Until the pain comes back, I wouldn't do anything.
So,
Of course, with medical supplements.
So
yesterday.
one thing, I don't know, and maybe I missed it, but I don't think you mentioned whether she has muscle spasm. Because and most of the patients that have injured nerve, they will have muscle spasms.
Yeah.
They will, and I think in those patients, that if they do have muscle spasm, and again, most of them do, you have to address the muscle spasm first. That's why Botox physical therapy, you get rid of the muscle spasm, and now if they still have pain and you're left with a nerve pain, I think that's when you start treating the nerve. But treat the most obvious thing first, and the most obvious thing is the one that you can feel on the exam, which is the muscle spasm. Because statistically, I really think in the diagnosis of pudendal neuralgia, the single most important thing is the mechanism of an injury. What really happened? And if you take that situation with a macrosomic baby with a vaginal delivery, still statistically the most common thing would be the muscle strain, the muscle pull, the muscle spasm. And pudendal neuralgia is a little bit more rare, so treat the most obvious thing. I'm not arguing she doesn't have pudendal neuralgia.
I understood that. Okay. We go on. And also we get the physiotherapist education, but additionally we made
Yes.
second, we made also pudendal nerve block 1 week later, but when you look at the literature, it says that 6 weeks later you make another block, but when you say this patient 6 weeks later, they escape. So together the patient and they come back, 1 week later we are performing, but the VAS course is good. But this is a personal experience. This is not a prospective randomized study, but in the literature, when you look at the 6 weeks later, another course must be.
So the 6 weeks purely comes from the fact that if you give steroids more often, you'll cause adrenal suppression. Yeah. So that's the reason why you do it 6 weeks later. Yeah. If you need to do it more often than 6 weeks, then there's probably no reason to continue the blocks, because she can't live her life having blocks every 6 weeks. Now, I have patients, several that I know very well, that I give them pudendal nerve blocks, let's say, every 8 to 10 months, because that's how long it lasts in them. And in those patients, I don't do anything else, because every 10 months you can get a pudendal nerve block, it's fine. You can't do it more often than every 6 weeks. So
okay. We are making more intervals, more frequent intervals.
Is VAS4 good enough?
for
VAS4 score, is it acceptable? Okay, but is it, for living a long life with score of 4?
I was going to ask the same thing. I mean, how her quality of life changed? I mean, the VAS score is 4, which is the limit maybe, because after 4 we start medication for acute pain, whatever it is. But the quality of life, how her quality of life changed along with this VAS score.
During 6 months, we are following the patient. Quality of life is good, but long-term quality of life, yes, I agree with you.
And I have to agree with you that the VAS is probably the worst possible measure for chronic. You don't use VAS for chronic conditions, so it's all about quality of life. And is 4 enough? I think it's up to the patient to tell you if it's enough or not. It also depends where your starting point is. If you're starting at 10, then 4 sounds fantastic. But if you start at 6, 4 doesn't sound that great.
Yes, we have forms about the quality of life forms. We are evaluating these patients, but the follow-up cycle of the patient is very short, 6 months. So we are following up. We don't know the future. But now during 6 months it is good, but yes, I agree with all of you that we must perform quality of life. And also the first month after the treatment, 3 cycles of blocks, the VAS score is 0. But the 3rd month after the treatment, we are following the patient, the VAS score again increased. What can you do in this case? And also curricular muscle physical therapy and blocks, but the pain again recovering.
You haven't tried the Botox? Right?
Yes. We made a transvaginal botulinum toxin injection. When you look at the literature, Michael knows very well that they are making pelvic floor Botox injections. But we are, in our routine practice, we are making half of them to the sacrospinous ligament, and the other half of them is the pelvic floor tender muscles. This is our routine practice, but there is no randomized control studies which area is better, unilateral or bilateral pelvic floor Botox injections. There is lots of literature, and this is the Pessover's route. It's experience. We are following his experience. He's making 50 units Botox to the sacrospinous ligaments and following the patient. And also we are making 100 milliliters Botox, 100 intervention units, and 10 milliliters Botox. 5 cc is sacrospinous ligament and 5 cc to the hypertonic 111 to the muscles. But it is Pessover's experience, and also it is our Pessover's rules. But it is discussable, and also there is no randomized control studies. Which one is better with Botox injections? But the third month is VAS course is decreased, and also during the 6 months we are following the patient's Botox, but pain is decreased, but we are continuing to follow the patient. Do you have any comment?
What is the mean duration of the Botox?
When you look at the literature and the Pessover's experience, we talk with him 1 year, 2 years. Maybe he says that there is no need to repeat the Botox. For example, he says that his experience. This is not a... We don't treat, but we are looking at the quality of life and what's the course of the patients. Patients is well, but during 6 months, we don't know another 6 months, but the Pessover's experience, he says that when you make a Botox, maybe 1 year, 2 years, the patient is free and feels herself well. But this is our experience, yes.
Completely disagree with that. It rarely lasts 3 months for, I done several thousand Botox injections to pelvic floor. I mean, I've been doing them for like 15 years now. Yeah. So very rarely it lasts more than 3 months. And in some patients it does. Botox chemically, if you look at the chemical, if you do an experiment in the muscle, it only stays there for 3 months. So after 3 months it's gone. So unless you do something else in those 3 months, like very intensive physical therapy, so you inject Botox and then you very intensive physical therapy, it will last longer. But if you're just doing Botox and nothing else, after 3 months it's going to wear off, and you're going to be exactly where you were.
Yes, but when you look at the literature, yes, we are going to physical therapy continue, but the pharmacologically it continues much more later, not 3 months, maybe 6 months or 1 year. The Botox additional effects there is. So when you make a Botox, the literature says that it makes some hydrodissection in sacrospinous and subtuberous ligaments, and also it doesn't irritate the pudendal nerve. So it is an additional effects of Botox or lidocaine's effect. So I think in literature it continuously much more. Its effect is much more better. Or for example, 6 months or 1 year.
The problem with Botox and injecting it around the nerve is that we actually talked at dinner yesterday about it, that there are some antidromal effects of Botox on the nerve itself when you inject it around other nerves, but they're fairly minimal. And Allergan, the company that makes Botox, they know that, they realize that. So they're doing a lot of research right now to identify which part of the particle of Botox has that effect, because it's not the same part that actually relaxes the muscle. So they are trying to purify that part of Botox, so that there will eventually will be a new medication that will be derived from Botox that will be specifically for the nerve blocks. But as it is right now, if you want to have any nerve effect from Botox itself, you have to inject fairly large amounts of Botox to get that effect. As far as hydrodissection, hydrodistension of the space, or Alcock's canal, or sacral tuberous, I agree with that, because we actually see this with our patients when we do CT-guided pudendal nerve blocks, when our radiologists use higher volume of the medication, patients tend to do better, and the thinking is that it mechanically opens up the space, but then you don't need to use something as expensive as Botox to do that hydrodistension. If that's truly a mechanical distension, you can just use regular saline I'm not arguing, I'm just giving.
I have a question.
Yes.
Thank you very much.
I wonder if you have such mapping that where you inject the Botox to the levator ani. Do you have any mapping? Can you?
There is a during vaginal examination and during physiotherapeutic examination. There's a tender points. Just when you look at the literature, you are applying the Botox to tender points or thought parts or tender points. You are using this, and with your physical examination, you are making a mapping. There is no another way to make a.
Any complication about the vessels or bleeding or?
No, not. You are not. Your root is 1 or 2 centimeters. The injection root. So so there is no vascular complication.
When we look at the literature about Botox, there's a very rare complication, but one of them is important. We haven't faced before. Anal incontinence. Okay, when you apply the Botox, you have to keep in mind that maybe 7% percentage is not high, but not less. It's a very important number. Do you have faced any fecal incontinence?
Minimal. I mean, it's probably less than 1%, and it's very temporary. I've never seen a patient incontinent for more than a week. Even though Botox works 3 months chemically, it's usually a week or less. And actually much more common is urinary incontinence, but the same than fecal incontinence, but it's still very short.
Directly to the levator muscle, or do you think that it's a distant effect from the other injections?
No, I inject directly into levator ani muscle. However, having said that, we have some patients that have such a prominent spasm that they can't have a bowel movement at all. They literally sit there with a teaspoon and they scoop out their stool out of their rectum on the toilet. And in those patients, I purposely inject Botox into the anal sphincter. About 10 units, so not that much. And sometimes it is difficult to know how much is enough and you inject a little too much. And they're incontinent, but they love being incontinent. After years of not having a bowel movement, they love being incontinent. They love their diapers.
Do you face with while making a Botox injection with sciatica or sciatic pain? Never. Because I think when you give much more 10 milliliters, it spreads to the sciatic nerve. The pudendal nerve is very much near. While making a subcutaneous ligament.
So I'm actually, my last lecture is about Botox injection, like the way we do it. So
Okay.
Thank you, Ahmet.
So my presentation is. My presentation, I did not know that this is going to be this format that, we call it Stump the Professor, that I'll be asking you questions. So mine has some questions, but it's nothing as cool as what Ahmed just did. So this is a case, 45-year-old nurse who in 2010 underwent total abdominal hysterectomy for large fibroid. She didn't have any symptoms of stress urinary incontinence, but her doctor decided to put a TVTO, the tension-free vaginal tape operator type sling, just in case. So basically this is the drawing of the tension-free vaginal tape, just in case. And patient was told, and unfortunately I don't know if that happens in Turkey, I think it's absolutely criminal what happens in the United States, but patients are being told by their gynecologist that you don't have any incontinence, but since I'm doing your hysterectomy, I'm going to put a mesh in you just in case you become incontinent 10 years from now. And that's exactly what happened to her. So the first question, why was the TVT done? Was that the ignorance of the surgeon? Is there an evidence that she will be incontinent? Was it a financial game, or was it a pressure from the mesh company? Which is the correct answer. All of them, but all of them, but most likely number 3, the financial gain. I mean, that's unfortunately in that model of medicine we have in the United States. There is clearly from the codes and billing when you do an anti-incontinence procedure, you get a lot of RVUs, which are the ways that physicians are paid in the United States, and also the pressure from the company. Of course, if you get gifts from them, you have to give them something in return. Immediately after surgery, she developed severe right groin pain with difficulty in walking. She was initially diagnosed with obturator neuralgia, and she had some blocks to the nerve, which relieved her pain temporarily. I'm sorry, I think I'm missing a slide. She then had the removal of the vaginal part of the mesh. Unfortunately, her pain did not get better, and she developed a pelvic infection which necessitated surgical debridement. She finally went to the world-famous Mayo Clinic. I always make fun of them because I actually trained at Mayo, so I'm allowed to make fun of Mayo Clinic. So she went to Mayo Clinic where she underwent laparotomy. For some unknown reason, patient had a TVTO and she underwent laparotomy, and that retropubic part of the mesh was removed of the TVTO. And she was told by the gynecologist, who I know very well, that her entire mesh was removed. Her sitting and vaginal pain improved slightly. She was also diagnosed with capillary leak syndrome, which is an autoimmune condition that I was never aware of. It's an autoimmune condition that may be caused by polypropylene. It's that capillary leak syndrome. It's a fun question that I show in the United States. That Mayo Clinic is the best institution on earth. It's a very good institution, but certain conditions may be worth to visit other institutions, and I have never heard of Mayo Clinic. I just make fun of these people. At the end, I mean, I have to summarize her story. She had 66 procedures, 66 surgical procedures to help her with pain. Well, combined vaginal, laparotomies, all kinds of interventional procedures to help her with pain. Well, the removal of the mesh was the first one. So after the initial surgery, she had 66 procedures. Okay, so the question is 66 procedures enough, not enough, too much, and stop doing surgery on that patient?
Not enough.
Not enough?
More surgery. More surgery.
Who votes anything else other than that? From the anesthesiologist? No more surgery. What do you say? Stop? Okay. I know any normal person in this case would say stop doing surgery on this, and anyone that has answered anything else must be abnormal. I'm sorry, but however, in that case, the correct answer was she needed one more surgery. So, moving forward, she's still complaining of significant tailbone pain, lower back pain, right groin pain. Pain is worse with sitting. She has, there's letter S missing. She has numbness in her right foot with prolonged sitting. Pain is better with laying down or in warm baths. Clothes irritate her symptoms, so she has allodynia. So again, this is her original TVT. And so what I do in my practice, and this is my patient I took care of several years ago, what we do in our practice, and this is really the key for all the patients with mesh injury, is because mesh is very difficult to visualize on the ultrasound, MRI, CT scan. And when patients had a mesh placed and they developed pain, and now they need, and they had parts of the pain removed, part of the mesh removed, you have to figure out if there is any mesh left in the patient. And so what we do, me and my fellows, we get their operative reports, we pretty much lay them down on the desk or we put them on the big monitor and we study them just like FBI would study evidence from the crime. And this is why I call our practice, patients love it, I know it's inappropriate, but patients love it. I call our practice CSI Vagina. Like there's no CSI Miami, our practice is CSI Vagina. And I told a patient that once years ago, and she's like, finally, someone is investigating the crime that happened. But you need to look and read those reports carefully, because this patient was told that her entire mesh was removed. But what in reality what happened is that she had the suburethral part removed, the vaginal part. And then the Mayo surgeon went in retropubically and removed the part of the mesh that sits behind the inferior ramus of the pubic bone. So what part of the mesh was still left in her? Is there mesh left in this patient?
Yeah.
Which part?
Behind the bone.
No, behind the bone they removed. Behind the bone they removed it through the laparotomy. Which part is? And everything that continues down. So the part that goes into the adductor muscles. How big is that part? Do we know?
No.
Okay. So patient is complaining of groin, whatever, she was diagnosed with arteritic pelvis. So I think my slides are a little bit mixed. So she had all these other treatments, acupuncture, norcopercocet, blah, blah, blah. At the end, what happened specifically with that patient, and that's actually, I have to tell the story because it's a fairly good story. So she was from Chicago, this lady was from Chicago, and one of my former fellows that I trained several years ago moved to Chicago. And my fellow decided that this patient has pudendal neuralgia. And she called me and says, that woman is in a lot of pain, she can't really travel too many times. I want her to fly to Phoenix, and I want you to schedule her for pudendal neurolysis, the way that I showed the transgluteal pudendal neurolysis. And keep the OR time, see her in the clinic on Wednesday, do her surgery on Thursday, and this way, And I said, sure, you're my former fellow, you know what you're talking about. So the patient comes into the clinic. The patient comes to the clinic on Wednesday, and I decided to examine her. And what I do is I look on her groin, where TVT comes out, and there's like a little bump. So I touch that bump, and that's actually where the mesh was coming. I touch it, and she jumps, and that makes her back hurt. Not even the place, but it makes her back hurt. And she's like, this is the pain that I'm having. I'm like, that doesn't sound like pudendal neuralgia, but it looks like this is the mesh that you have. So what I did is I took lidocaine and I injected in the office that spot. And after 2 minutes, she says her back pain went completely away, just by injecting that spot. So what is her? I'm going to skip that. So this is what I did. I injected the lidocaine in the groin, and her back and foot stopped hurting. So one thing is that we're forgetting is when those TVTOs are placed, that part of the mesh in the groin, in the adductor muscles and the obturator fossa, it is actually a very long part. And if you look at the length of that part, is sometimes even up to 10 centimeters. And so when patients are told that the entire mesh was removed, and you read the report, and the only surgery that was done vaginally, you know that the entire mesh is not removed. So what's your diagnosis at this? I know I jumped ahead. What's the diagnosis at this point?
Retained mesh?
Retained mesh.
Relating to obturator nerve.
Yes. Well, for that there was really no, but it's definitely a retained mesh. The injury to the obturator nerve is sometimes difficult to tell for several reasons. The obturator nerve block is not very easy. You need to make a very selective block to confirm that. But just the fact that you're putting the mesh through the adductor muscles causes a lot of tension.
Dr. Michael, the mesh maybe irritate the obturator nerve, not injury. Maybe irritate you because
it's very close.
Going to obturator
it's very close. So it's probably about a centimeter and a half. Yeah. So the following day, I canceled her pudendal neurolysis and I said, I'll remove your mesh. That was years ago before I knew. Now there's many people that take the mesh from the groins. There's Veronica's in St. Louis and Shlomo Ras in LA, and we do that, and John Miklos in Atlanta does that. But at that time, I didn't know of anyone that takes a groin mesh out of the groin. So I really didn't know if it's safe to cut into the groin, and I didn't know who to ask. Should I talk to the orthopedic surgeon? Should I talk to somebody? So I did the only right thing I could do. I just did it myself, because if I started talking to people, then no one would give me the correct answer. So what you see here is, well, this is the vaginal retractor, the vagina here, and what you see here is the incision in the groin itself. So I have better pictures in a second. So the incision goes into what's called, anatomically that part is called a genitofemoral crease. So that's basically where the leg attaches to the perineum, that's that crease. So we make the incision right in the crease. The incision is about 5 centimeters long, and then sometimes the mesh is very superficial. Most of the times you need to dig through that. So you cut deeper and you cut through the fascia of the adductor muscles, and then if you still can't find it, I take a bovie and I cut the adductor muscles. Of course, the first few times I couldn't sleep all night because I didn't know if the patient would be able to walk, if the patient would be limping or falling over, and I've done at least over 100 of those, and I had not a single. I had a patient that developed an abscess, and I had patients who didn't get better, but I had not ever had any complications with walking. So what you see here is, of course, the skin incision. Those are the adductor muscles that are pretty much cut. I don't ever cut the adductor longus, which is that muscle you can feel the best. It's that thick tendon. But I cut all the other muscles, and this is, as you see, there's a piece. This is I think from a different, maybe from a different patient, but you see this is most likely the TBTO mesh because it's blue and Monarch would be white. No, she had a TBTO, so maybe it's her. So you see there in the cochlear clamp there is a mesh. And again, there is another one, and I think I have, there's a video of it. So you see the vaginal part of the mesh, and you see the groin part, and you see it's completely free between the vagina and the groin. So at this point, on this particular patient, we remove the entire arm. So you have to go vaginally and behind the pubic bone, and you have to go through the groin, and you have to meet somewhere behind the bone. And as you see, the entire piece of the mesh was removed. Now, so the piece of the mesh from the groin that was removed was 9.2 centimeters. So that's a very long piece of the mesh. So this woman had 66 surgeries. She went to Mayo Clinic, where she was told by a chair of urogynecology at Mayo Clinic that her entire mesh was removed, and this is what I found in her. Here what I wanted to show you, and this is, I don't know if it's from her, I may have some patients mixed up, but more of it as a teaching point, that very often the mesh is very adherent to the pubic bone. Like it's almost behind, and you can't remove it. And in those cases what I do is I take an osteotome, and I actually cut a little piece of the bone so the mesh comes out with a sliver of the bone, and you'll see it here. Basically, this is the osteotome and the mallet, and what you do is you put it behind the mesh, just like the orthopads would do. And you amputate very tiny piece of the bone. And then at the end, when you lay down the mesh, there's like a little piece of the bone that's attached to that, because that's the only way it will come up. I think as the TBT is placed and TBTO is placed, and that needle travels around the inferior pubic ramus, it scratches the periosteum, and it causes the adhesion of the mesh to the periosteum. So, yeah, sorry, this goes vertical because it's taped on the iPhone. So this is pretty much how we remove the mesh. Not everybody needs the osteotomy part. So one day after surgery, she felt that her pain, the pain is gone on that side. Now she starts telling me she didn't have pain on the other side, but this is very typical with patients that they come and complain on the pain on the left side. Let's assume it's left side that is horrible, and they don't tell you the pain on the right side because they never felt it, because this was so bad that they never noticed that pain. You help them with the pain on one side, and now they're coming back saying, now I hurt on the other side. It's not that you gave them pain on the other side. They always had it, they just never felt it. So basically I did an injection on the other side, and I think a month later or so, I did remove the other side. She's more than 2 now, she's about 4 years from surgery. Those are slides from 2 years ago. She's about 4 years from surgery, and she's completely pain-free. So the point is, if you have patients that had transobturator mesh, and they're complaining of a groin pain, they have to have that leg part of the mesh removed.
While you are doing your groin incision and going deeper, do you encounter any important vessels or nerves, something like that?
There's no vessels, but we have to be careful or cognizant of the obturator nerve. And you know, and I'm sorry, I don't think I have that slide here, but on some cases we use a neural stimulator. So we find that, remember the obturator nerve will be all the way lateral. Yeah. And the mesh should be all the way medial. But there's a little neural stimulator device that you can actually stimulate if you see something that looks like a nerve, you can stimulate it and you can see where the leg is twitching. So you can tell the obturator nerve that you sometimes see it, but usually you don't come close to it. And there's no problem with vessels. But there's no vessels. I mean, maybe there are, but I've never seen them. All right.
Thank you, Michael.
Hi again. This young lady is 29 years old, married, and there's no child. Complained dyspnea for 2 years. She was operated because of chronic pelvic pain, and 1.5 years ago, and they didn't find any specific findings. Temporary, she's complaints is gone, and then complaints come back again, and she complains same pain 3 months later after surgery. What did you do? What would you do after this one? 4 years. The operation was performed in another hospital for chronic pelvic pain.
Did they have any operation about the endometriosis focus? What did they?
But small spotting.
Spotting.
Some small black spotting. There is no any bigger lesion.
How did her pain start?
Start in the abdomen, lower abdomen.
What happened when it started?
There is no specific
Nothing.
motion.
So did she wake up one morning with a pain, or was it getting worse, like slowly, progressively getting worse?
She said, my pain is coming and then it's going up, but no moment or no specific activity affect the pain severity. And it's going on the whole day, but the severity is not high. It's in the middle of the abdomen and the lower part especially.
Worse in the morning or in the evening?
There's no difference between the morning or night.
Does she wake up at night with pain?
No.
When she wakes up in the morning, is she in pain? So what I tell patients, when you wake up in the morning, if you never got out of bed, would you be in pain?
She said, I have a little bit pain, but the pain is not related with that one.
So then it gets worse when she starts doing daily activities?
No.
No.
Any other symptoms, like GI symptoms?
There's no specific gastrointestinal complaints.
Urinary complaint, fever, etc.?
No fever.
You mentioned about dyspnea for the first complaint, and then she complained same pain. So,
Yeah.
And also you mentioned that she had a continuous pain.
Yeah.
Which one is that?
Dyspnea is the main complaint, but after that she said that chronic pelvic pain.
How does the pain radiate?
There is no irradiation of the pain. It's on the pelvic region. There is no irradiation. There is no going to foot or legs.
Is the pain after intercourse, after sex also, or just during?
After sex, it's increasing.
Okay, so it's during and after.
Yeah. I forwards. During the pelvic examination, there was tenderness and pain right down next to and anterior vaginal wall. When we applied the neuropelviologic examination, there was no pain on the sacral nerves 3 and 4 and pudendal nerve bilaterally. Transvaginal ultrasonogram normal, uterus and ovaries. We think that pelvic pain due to adhesion, but we read her operation report. There is no specific adhesions. And is there any chronic pelvic inflammatory disease? We speculate. Is there a bladder problem? That's all. What would you do when you face after the examination?
So, you know, a few more questions, like any history of abuse, any history of...
We asked, she said no.
You know, some other activities, because to me, just if I had to like guess right now, without going any further, I would say she has pelvic muscle spasm. But does she, so people that are predisposed, and this is probably not for you, but people that are predisposed to muscle spasm, let's say they don't have like any trauma, any whatever, that's common in women. They're usually like gymnasts, or they work out, or they're ballet dancers, or they do like core body activities. So do you know if there's any, I ask patients about it. Did you do ballet when you were a little girl, or gymnastics? Because those are very strongly correlated with that.
We use one questionnaire, a questionnaire about some defecation problem, gastrointestinal or urinary problem, and I can guess that you cannot clearly see the what writing on the street. There is some problem about the pain on the limb, and there is some bladder problem, and the patient said that I have some pain during the mixtion. Mixtion.
Oh,
urination.
Okay, so when patients have pain during, so that's also a very important question.
Yeah.
Is the pain when the bladder is full? Is it during urination, or is it right at the end of the urination?
The patient said that I feel some pain during the urination, not full, but when my bladder is full, the pain is going to increase, but the level of the pain is in the middle of the scale.
Okay.
But there is only information about his pain, her pain. Minimal decrease, but it's going on. He feels the pain again.
Is there pain above the sacrospinous ligament?
No, I say pelvic examination and neuropelvic. There is no tenderness point in the vagina. There is no pelvic pain, muscle problem. Okay. We think that we have to start your empiric treatment. If there is no improvement, maybe we can start with the Dianogest for endometriosis, diagnostic laparoscopy. Does it work to do it? We are not sure. 1 month later, after antibiotic therapy, during vaginal examination, pain limited to the anterior vaginal wall. Normally, when we examine, we feel some pain on the adnexal side, but we completed the adnexitis therapy. The pain is on the middle side of the vagina. It's only located on the anterior side. And then we want to exclude endometriosis, okay? And we add the Visan treatment for this patient. And we think that there might be some problem on the anterior part of the vagina. Maybe we can find some things in the bladder, and because of that, we recommend her urology consultation. Yes, Michael.
So I have a question. I'm sorry I asked a lot of questions, but and I know it may be too sensitive. We ask those questions. I don't know if we do, if you do, but if patient says that her most significant symptom is pain with intercourse, with sex, and her pain is only on the anterior vaginal, do you ask them in what position in sex do they have most pain? Because that
it's a good question. We always ask him, do you have a pain during this position or another position? Could you explain your position? And the patient said that there is no any information about that. Especially deep sexual intercourse. We always ask about deep endometriosis. And our urologists recommend us CT urography and cystoscopy. Would you recommend her CT urography?
No. Maybe for endometriosis, I don't know.
No, it's not for endometriosis. Normally in endometriosis we don't use the CT urography.
It's not interesting in situations.
Yeah. But they apply the cystoscopy. The main question is maybe this lady has endometriosis, or is there any bladder problem, for example interstitial cystitis, and they applied cystoscopy. The CT urography is normal, and they find 100 ulcers in the bladder. Okay? They make a hydrodistension and make some monopolar ablation in that cystoscopy, and the diagnosis is interstitial cystitis or bladder pain syndrome, and it's going on. Okay.
They did some biopsy.
Yeah. Yeah.
Excluding the
Other.
carcinoma.
Yeah. The lady is 29 years old, but they took a biopsy. The biopsy is normal.
No.
The main problem is the diagnosis of the interstitial cystitis. The biopsy is not pathognomonic. Aneurysm is not pathognomonic.
Actually, there is no any pathognomonic.
Yeah. But the last diagnosis is interstitial cystitis of this young lady. Ben sana sormak istiyorum hocalarıma da. Şimdi süreyi biraz geçtik. Vakalarımız var. İsterseniz bir vaka daha alabiliriz veya ara verip son oturumumuza geçebiliriz. İsterseniz oylayabiliriz. They make a hydrodistension and they apply the monopolar ablation during the same session. And then they start the Elmiron.
The pain decreased?
But the main problem is this lady is 29 years old. She have a very long life, and how can she deal with it? I don't know in the future.
Does the pain decrease?
Yeah, the pain was decreased after the treatment.
And dyspareunia disappears after that?
Yeah.
Dyspareunia is decreased, not 0 point.
Is it really related with dyspareunia and interstitial?
Yes.
What do you think?
No, I don't think so.
Ahmed, when you touch the anterior vaginal wall, she feel pain.
Urologist doesn't
Yeah.
say that it is not much more related with the dyspareunia and interstitial.
But if you touch,
on the exam, if you touch it with a finger,
yeah, you have to touch.
then her husband, whoever, touches it with his penis the same way. There's no difference between, well,
Yeah.
There is not so much correlation with interstitial. I don't think so. It's like, just go on.
Yeah.
It's not clear. I think maybe genitofemoral or other nerve entrapment.
How can you diagnose
Because
that
after
one?
operation, the patient have an operation. I think it's laparoscopic operation. Maybe there are some entrapments.
But the pain is on the anterior vaginal wall. Okay,
Right.
there is no vulvodynia. There is no pain.
Firstly, you didn't say it. You say low abdomen.
What kind
Yeah.
of nerve entrapment do you think? What
Genitofemoral.
operation is middle side, not lateral side? Because to injure the genitofemoral nerve, laparoscopy.
Because
or histories, there is
it's-
a laparoscopy.
But this diagnosis is not successful.
You are not agree with the urologist diagnosis, is that right?
yeah.
Yes.
We believe the urologist.
Well, I think it's also, unless she had a
Maybe
trauma,
diagnostic block is enough.
But this lady hasn't got a unilateral pain, okay? The main problem is if you make a diagnosis about the somatic nerve, okay? The patient said that I have a pain on this side or this side, okay? This lady has got a pain on the center side of the pelvis.
I have one case like this. After diagnostic block, we think, because nobody say anything about it. After genitofemoral.
But where is the? But I do. For this case, I don't agree with you. For genitofemoral nerve entrapment or injury, the person's surgical anamnesis is not related with genitofemoral injury. Because, for example, if the patient had previous oncological operations, lymphadenectomy, yes, maybe. Because genitofemoral nerve is over the iliopsoas muscle. So, and also genitofemoral nerve area is not the central area, the pain. Radiating to the leg is anterior leg and proximal side of the leg, and also labium majus. But the patient's
maybe other entrapments.
What entrapments? But what kind of?
We have three nerves there.
But iliogastric ilioinguinal nerve is much more superior than the genitofemoral nerve.
Well,
so it is not related with this type of pain.
Well, I think it's also unlikely. It's possible, but it's unlikely to have a nerve entrapment without injury in a 29-year-old. I just don't think it's very likely. So that's why I believe that the most important thing in diagnosing patients by far is talking to them, because they will tell you what's wrong. And if she never had any fall, any injury, I mean, you could have a anatomical defect that the nerve is entrapped, but it's just unlikely. So the people with genitofemoral injury, they have some kind of a lunge trauma, lymphadenectomy,
gynecological cancer operations, retractors, deep retractors, yes.
After cesarean section, I have a case, one case.
Yes.
One case.
Cesarean sections operations is too much. It is related with
Ilioinguinal and iliogastric.
Not
That's true, cesarean section, but she didn't have a cesarean.
Yes.
Mola mı verelim? Hocalarımıza ne? What would you do? Do we go to break or going on? Which one do you want? Salon ne diyor? Peki. This is my next case. This lady is 24 years old, married for 6 years. She complained about pelvic pain for 3 years. One orthopedist consulted this lady, and that colleague said sacroiliac trochanteric bursit, and they recommend her left MRI, and the MRI results was normal. They recommend her non-steroid anti-inflammatory drugs, but the pain is going on, and after that they recommend the patient steroid injection of the hip joint, and they applied, and they ate selective serotonin reuptake inhibitor, but there is no answer. The pain is going on. They gave him Laroxil, and they start with the physiotherapy, 15 session for left hip. 1 month later, algologist said, during examination, you might be piriformis syndrome, and that colleague applies steroid injection on piriformis muscle and trochanteric bursa. And then they apply the MRI for cranial reasons to exclude the MS, but the results was normal. The pain is on the left hip, okay? This look like this one and go back side, but there's no going to the heel.
What's the character of the pain? What's the character of the pain?
Pain start in the morning, but it is increasing at night.
Pain, neuropathic pain, burning sensation, stabbing knife, what kind of pain?
More stiffness.
Step by step became going on. First,
What kind of pain?
she said that I cannot walk after 15 minutes. When I walk or doing something, my pain is going to increase.
It's a dog pain then?
Yeah.
Didn't she lay down on this affected side?
Yeah.
During nighttime she doesn't have any pain.
Yeah.
And
At at night time it's increasing or daytime.
Is it related to any movement or position?
No.
So it's not worse with walking?
It's worse with
Worse
walking.
with walking. Okay.
And when the pain radiates, so it's very important.
Yeah.
It's starting from the anterior part and
Going to backside.
to the back side.
Yeah.
It's not from the back to anterior.
Tight.
And the MRI.
Not anterior side.
At the tight, you mean on the posterior part of the
Posterior part. She showed it start with this place, but there is no irradiating on the vulva or vagina. It's going to tight backside.
by sitting, standing up.
Stand up is the pain is going to increase.
And what about the results of this treatment?
There is no answer.
Any answer?
Any answer.
Do you think lobar is herniated or another sciatic?
The neurologist said no.
No.
The
The posterior femoral cutaneous nerve entrapment, do you think the lesser, the small sciatic nerve?
might be.
So she had 15 sessions of physical therapy,
Yeah.
physiotherapy. What did the physical therapist?
Minimal effects.
No, but what did?
I'm sure that they only put some devices, that's all. It's not the physical therapy looking at your treatment.
Okay.
I don't
Well,
think
because
it's-
usually they will tell you, like the physical, like if they do manual treatment, they will tell you, like, you know what's going on.
And I'm going on.
I don't know the patient, so it's
Oh,
not. It's the first time, but I'm sure that this.
You know this patient.
Devices.
We discussed in pain.
Dr. Taner, I didn't understand this sentence. Neurosurgeon recommended hot application to preformis, cold application to trochanter.
Yeah.
What is?
I don't know. This is the patient's explanation.
Meaning is to relax muscles.
Maybe, yeah.
Reduce inflammation.
Does it work?
Yeah.
Are you sure it's not happening?
Yeah, the MR was normal.
For the muscle.
Yeah.
Usually
Yeah.
works for the nerve thing.
But the orthopedist said that this lady has got a sacroiliac, trochanteric bursit, and after that they applied a steroid injection at that joint. And after that, one neurolog saw the patient, and that colleague applied EMG, and they find normal sciatic nerves. And the patient sent to psychiatrist. We discussed it in the morning, and they gave antidepressant again. 6 months later, one algologist recommended steroid injection, but she refused it. And then one orthopedist said that external snapping hip syndrome, but the patient doing nothing after that. And then 1 month later, she had 20 sessions of physiotherapy again. And then neural therapy was recommended. And diagnostic arthroscopy was recommended. Pain start after right hip, so she gave up the arthroscopy. And the pain is going on. What would you do in this step? Orthopedist, neurologist, psychiatrist.
No, go ahead. No, please. I would selectively block some nerves in her.
Which block?
Everyone I can block, so just start with the most obvious. No, I mean, start with the posterior cutaneous femoral nerve, and then
femoral nerve.
Posterior cutaneous femoral nerve. And then lateral cutaneous femoral nerve, and just kind of the ones that you can block, you just have to do them one after another, not all together, because you block them all and then you don't know which one worked.
Yeah. After that, 3 months later, she had 5 sessions of neural therapy, acupuncture, oxygen therapy. One rheumatologist recommended him some tests for heavy metal, and she took some treatment for heavy metal, but the situation is the same. The pain is going on. 2 or 3 months later, one person applied the leash treatment, sülük, but the pain is going on.
On the face?
No.
On the buttock.
When we examine this patient, this is the story of typical chronic pelvic pain cases, okay? You can see a lot of patients like this one. Michael showed us 66 intervention or surgeries.
Yeah.
This patient is look like the same one. During the gynecologic examination, vaginal introitus was very tight. Transvaginal ultrasonogram was normal. During neuropalliologic examination, there was no pain or tenderness, sacral nervus or pudendal pain. There was a pelvic muscle spasm on her left perineal and vaginal side. It was too painfully, and it's not easy to examine the vagina. Right perineal vaginal side pain was less, and there is no spasm. Pelvic floor muscle spasm, it's in the inferior vaginal wall, and we recommend her MR neurography. During the MR neurography, the report was show us asymmetric thickness of levator ani, more prominent on the left side. The patient's main problem is on the left side. Pelvic some varicose veins. And there is some abnormal veins, S1 and S2, on the left side, and it's very close, and some varicose vein on the right side, but there are no relation with the nerves.
Vascular nerve and trapdoor sacral nerve roots, maybe.
Yeah.
The
The diagnosis is that one, but we find levator ani hypertrophy, and this result confuses our mind. What would you do when you face levator ani hypertrophy on the posterior side and you find some vascular entrapment on the same side?
Well, you know, we too often forget, and actually this was my very first thought, but I changed my mind for some reason. We too often forget that the operator internus muscle actually attaches to the hip, because that's the function of the operator internus. It's in the pelvis, but it's there to move the legs. So very often patients with operator internus spasm have the leg pain, or the hip pain, because it attaches to the trochanter. So I think at this point, if I was treating her, I would ignore all her findings other than treating the spasm of the left operator internus muscle. However you do it, Botox, physical therapy, because I assumed that she had physical therapy, but it was an external physical therapy for the hip. It wasn't the pelvic. Yeah. And get rid of that first, of the left operator internus muscle spasm before doing anything else.
Does physiotherapy therapy or another Botox or steroid injections works, or do you
No.
such kind of operation?
Some of the colleagues apply the steroid injection, but there's no answer. But they apply the steroid on the joint.
I don't think it's the joint, it should be on the trochanter first.
Maybe.
It doesn't work.
We discussed this patient in our pain consult, and we applied first of all the easy way, because this woman is not in good condition, especially the psychiatric situation, but the pain is a little bit less after the injection. But before the injection, we gave him information about this intervention. We start the pregabalin and some drugs, but they didn't work, and we sent her to psychiatry because the anxiety is very high. And then we discussed this lady again in pain consult, and we think that we have to apply Botox injection of the pelvic floor, and we applied 200 units of Botox. Could you see that 50, 40, 40, and less the other side? The pain is, yeah, no.
So just tender.
Yeah.
Okay.
So can I make a comment? I'm sorry.
Yeah.
I'm talking a lot. So on this drawing, there is no number on the operator internus muscle.
Yeah.
That's where the spasm
Yeah.
is. The operator internus.
How can you sure obturator internus muscle? Because of walking?
And I thought you Well, because of her hip pain, of the radiation. So yeah, obturator internus muscle is the muscle that externally rotates the leg like this, which is something that you do during walking. You stabilize your leg. So when your hip hurts and it's involved with a muscle spasm, it's usually the obturator internus muscle. Well, yeah. That's
Yeah.
specific obturator internus.
They decrease, but the amount is a little bit less. 7 or 8. Now the VHS score was 5. And then we discuss the patient. You have some abnormal varicose vein on the same side. Maybe we can wait and maybe we can make a surgery. And then we apply the surgery on the left side. When we apply the surgery, we find some abnormal vein. This is the first one. It's on the lumbosacral trunk, this one. And it's compressing the lumbosacral trunk. This is some arteria, and we cut that vessel. And there is huge aberrant vein on the medial side of the lumbosacral trunk and the sciatic nerve. We find the proximal part, and then we block the proximal part of that vein. And then we cut that aberrant vein. Cerebral nerve, lumbosacral trunk, sciatic nerve, and that one is the S1. We performed the surgery 3 or 4 months ago, and the pain is going to decrease. And now she's fine. And the pain is 2, 3, between 2 or 3. That's it. Michael, you applied only Botox injection and first physical therapy, intravaginal side. You don't operate this lady, is that right?
So what I would.
What would you do?
What I would do is like when a patient like this comes in, the day when they come in, we send them to physical therapy right away. We set them up with physical therapy. We actually have a therapist in the office, so it's easy. And we always give them vaginal muscle relaxants. For some unknown reason to me, at least in my opinion, the oral muscle relaxants do not work for pelvic floor muscles. I have no explanation why. What really works well are the transvaginal muscle relaxants. So we give patients compounded suppositories with 3 medications: Valium, baclofen, and ketamine. And they're to be compounded, mixed by a pharmacy. And in the United States, it's not a problem, but I hear that in other countries, like ketamine is illegal, and like you can't make compounded suppositories. There's like a lot of issues. So if this is not available, the vaginal Valium tablet, the regular 5 milligram oral tablet of Valium, patients just can put it vaginally and it still works. And I usually give this, the vaginal muscle relaxants and physical therapy, I would give that maybe 2 months, because that's usually how long it takes to see if it's going to work or not. And then the Botox would be the next step. The thing that I do is when I inject the Botox is that I send patients to the same physical therapist that examined them before, and I do it within 10 days. Because Botox takes like 5 to 10 days to start working. Because I need a therapist to tell me if the muscle has relaxed. Because if it hasn't, it means that I either didn't inject enough or I missed the spot where it needs to be injected. And then I tell patients maybe you need more Botox. But if the muscle is, per therapist, if the muscle is relaxed and they are still hurting, that's when we move to the next step, like surgery or something.
Sorry, for Valium everyday Valium, intravaginal Valium?
Usually the patients start with, they put it vaginally before going to bed, in case it's too sedating. It usually doesn't sedate them. It makes them sleep better, sleep through the night. A lot of patients like this get up at night multiple times to go to the bathroom, which completely disrupts their sleep. And so it helps them sleep, relax the muscles. Now, during the day, if
1
they're...
week or 2 weeks?
No, they take it forever sometimes.
Forever.
And a lot of patients, those that have pain with sex, with intercourse, I tell them to use it before sex. I just tell them try not to fall asleep.
I'm wondering the long-term effect of physical therapy about this case. This is a young lady. We can apply the physical therapy intravaginally, and maybe the patient said that, how long do I have to use the drugs? How long do I have to use the physical therapy session?
So
What's your experience
sometimes
about
those patients go to physical therapy for a long time. And when I mean a long time, a year or longer. But what is important with physical therapy is not only the transvaginal manual physical therapy, but the therapists also teach the patients of what to do and how to do it. How to sit, how to breathe, how to stand, how to walk. Because all of these things affect pelvic muscles. So a lot of physical therapy is not only the manual therapy that they do, but it's the education that they get, which eventually helps them. Because if they, in her case, I forgot, well, in her case, she had congested veins, but sometimes they have spastic pelvic muscles because of postural, like, they don't sit right or they don't stand right. There's someone much smarter here to give that answer than me. So the point is that the patients need to be taught de novo, like from the beginning, how to do that. It's like, I need to teach you how to sit, because if you don't sit right, your muscles will spasm again. So that's the goal of pelvic physical therapy, in addition to other goals.
Is there any comments, additional comment from you? O zaman kapatabiliriz diye düşünüyorum. Bir 15 dakika sonra tekrar başlayacağız.